Jack, isn't he, Bressie? I mean, he's 19 to come out and be that courageous.
Yeah, I mean, I wasn't courageous enough at 19 to say it. And the thing about it is, it's the message that we need to get across more than anything is that it is dealable with.
Yeah.
We have this mythical, haunting approach to it, that it's some demon that we have, and at the end of the day, it's scientific. It's, you know, there's a way of treating it. It might be, in my case, I went through a few different routes to find where I had to go through. What we said is, like, once you talk, you've two roads, and we want to block the road. That idea of that's even an option. Suicide should not even become part of the conversation anymore. But this road has so many options, and the one I took was personal fitness. I did the maths essentially on it. I knew that, you know, what does fitness do? Serotonin levels, it raises serotonin levels. So I said, well, we'll give this a go. I set myself a goal, which is probably a very important thing as well. I'm doing my first triathlon in a couple of weeks. I never swam really until January, but I felt if I gave myself a goal and I trained for something, maybe this will work, and it did.
Great.
It won't work for everybody.
Yeah,
that's the approach I took. You know, but there is so many approaches to take, and as soon as we realise and we talk about it, you'll see that there are so many roads to take that isn't, unfortunately, suicide.
Psychiatry in all of this time doesn't have one case report of one disease validated, not one. What they do is they meet at the American Psychiatric Association. They meet in the DSM committee, Diagnostic Statistical Manual Committee, and they vote on making new behavioral and emotional disorders. And they vote, and then they start immediately calling them diseases. And they tell people, they tell the public, these are diseases. Total fraud. Total fraud.
The actual truth about chemical balance is that it's an actual lie. Nobody has yet measured, demonstrated, or created a test to show that somebody has a chemical imbalance in their brain. Period.
What the American public should be thinking about is when they or their loved ones or their friends have received a psychiatric diagnosis, they should be asking the doc, geez, doc, where's the chemical test for that? Where is the objective test for this? And I guarantee you that they'll be told, we don't have a chemical test for that.
There are no biological tests for any mental illnesses that I'm aware of.
There are not current available tests to verify your diagnosis.
There is no test. There is no specific test to differentiate between, let's say, schizophrenia and bipolar disorder. Not a single test.
Yeah, we have not really confirmatory test for the diagnosis.
There is no test, there's no biopsy you can do that says this person is depressed, this person is bipolar.
We don't have anything really currently to identify mental illness per se.
No, there are no specific tests to confirm the diagnosis or show the improvement, like any blood tests or any x-rays or anything like that.
Oh, in my practice I don't do any tests. I just speak with people and listen to them, and then I make a decision in what kind of illness there should be.
We don't really have any specific blood tests or other tests that are definitive for any mental illness whatsoever.
What kind of biological tests do we have available today for detecting mental illnesses?
None.
There is no rational science behind what they think is the cause of these symptoms. The medications that are being given to people are, without exception, introducing chemicals that are altering the brain in ways which can be very damaging. And I'll go a step further and say that in the absence of a proven chemical imbalance for which the medications are, quote, rebalancing or fixing, the medications are in fact toxic.
How many patients have you been able to cure so far?
I would say one.
How many people have I cured? Well, there are no real cures right now in psychiatry.
The idea of you asked me about the issue about how many people I've cured. I don't know that any of us are ever completely cured of anything.
I have not been able to cure many patients.
I have cured none of my patients.
So you have to ask the classic Roman question, legal question, cui bono, who benefits? The people who make the diagnosis.
Jim Lucy, you're in charge of that place, St. Pat's, that Jack praised so much, probably largely saved his life.
Jack's a wonderful man. I mean, that's the man who needs to be praised here.
And when you, though, I've got to name check the Moira and John O'Sullivan there talking about their son Alan, and Martin and Cora O'Brien about David. I mean, break your heart.
I think everybody here in the studio, and I'm sure at home, is feeling the enormous emotion and power of the testimony that people have given. And I think it's hugely generous of Jack and Bressie, but also the people from Kerry. I mean, people listening here, there will be people at home contemplating despair. There'll be people here bereaved for those who've ended their lives by suicide. And there'll be the others who are thinking maybe there's no point in going on. And what we need to do is to realise that that's real pain and that's real suffering that can be addressed. People need to be able to speak up and come and get help. The bulk of suicide arises from treatable mental health distress.
Hi there, my name is Terry Lynch. I'm an Irish medical doctor, psychotherapist and author of books on mental health. Currently I've written 2 books. My first book is called Beyond Prozac and more recently Selfhood. And this is one of a series of videos that I'm going to be making about mental health, and in particular about truth in mental health. Truth in the psychiatric approach to mental health, and in presenting ideas as to how we could understand mental health in a deeper, richer way. The purpose of this video is education, really, education about serotonin. And I've picked serotonin because serotonin has found its way into everyday conversation. People mention serotonin and serotonin levels now in ordinary everyday conversation, as if it has been proven that a low serotonin is responsible for depression. And I believe that this is the result of quite a successful information, or should I say misinformation, campaign to inform the public, or perhaps misinform the public, in regard to depression, and to present a simplistic idea of depression, that it's caused by low serotonin levels. And it's worth looking at this statement and seeing how true it is, and that's the purpose of this video. And in this video I'm going to compare depression to diabetes. For the past 20 years or so, many doctors in their discussion about depression have compared depression to diabetes, including statements that both of these conditions are caused by chemical imbalances. So a comparison between the two is therefore very appropriate. Now, I'm not suggesting that antidepressants do not help some people, but the public are entitled to accurate information. In my experience, working with people diagnosed with depression for over 20 years now, antidepressants appear to be fundamentally mood or feeling altering. Many people, for example, taking antidepressants feel numbed while taking them, and for some this may be a welcome relief from intense distress, and this makes sense. In some people, antidepressants have a stimulating and sometimes an agitating effect, and there is evidence now to link antidepressants with suicide, to the degree that warnings in relation to this are now contained in the packaging of these substances. Stopping antidepressants can be associated with considerable problems, and this video should not be taken as recommending or encouraging individuals to come off psychiatric medication. The purpose of this video is educational, to provide the public, to provide you with accurate information regarding antidepressant drugs. And it seems to me that the public are entitled to accurate information. So, depression and diabetes, and this issue of chemical imbalances, comparing the two. First question, the obvious question is, well, what's the chemical abnormality? In diabetes, there is no doubt. The chemical abnormality is that blood sugar is raised secondary to a deficiency of insulin. That's it in a nutshell with diabetes. Very simple, very clear. It's not at all like that with depression. Doctors talk about low serotonin as a possibility, but they also talk about other chemicals, such as low noradrenaline or melatonin problems more recently. And there's an adage in medicine that if doctors are presenting 3 or 4 ideas about something, it generally means they really don't know which is correct. Whereas with diabetes, the situation is very clear because we know. Next issue then is the diagnostic test. In diabetes, the diagnostic test is simple. It's a blood sugar level. And this test is always done when checking somebody for diabetes. It's always done. The diagnosis of diabetes is never made without having done a blood test or a series of blood tests for blood sugar. And the blood tests for diabetes are 100% reliable. Compare that to depression, where there is no test because there's no test available because it doesn't exist. Therefore, the diagnosis of depression is always made without chemical tests. And the tests have no reliability because there are no tests. And if you're looking at diabetes again, no doctor would ever diagnose diabetes without the chemical tests. And any doctor who did that would very likely find themselves accused of malpractice. Whereas precisely the opposite is the case with depression. Depression is always diagnosed without chemical tests. Next question in terms of a chemical imbalance is, well, what are the normal levels of the chemical and what are the abnormal levels? In diabetes, as in other chemical abnormalities such as thyroid problems, the normal expected range of the chemical is known. Final med students know what the blood sugar should be. And we can only know the abnormal level of a chemical if we know the normal level. I mean, that's common sense. Yet in depression, ask any doctor, what should my serotonin level be, doctor? And they can't answer that question because we don't know. And if we don't know what the normal level of serotonin should be, how on earth can we speculate on abnormal levels? It's worth saying that the only thing we can be relatively sure of in terms of antidepressants and serotonin is that they interfere with the uptake of serotonin in the synapses between brain cells. In other words, the spaces between brain cells. We do know that they have that effect. What we don't know is whether the levels were normal or abnormal in the first place, or whether interfering with serotonin levels in these synapses is a good thing or a bad thing. We don't know. Obviously, if we're talking about chemical abnormalities, we should understand the function of the organ we're talking about. And in diabetes, for example, the organ we're talking about is the pancreas. And doctors understand the function of the pancreas very well. And the microscopic findings in diabetes of the pancreas, for example, they're always the same. Little particles called the islets of Langerhans, they always have the same changes in diabetes. Nothing like that exists for depression. There is no part of the brain that we can say becomes changed in a reliable, predictable way in depression. Then the treatment. The treatment for diabetes is all about correcting the chemical imbalance. With insulin, for example, you're replacing like with like. Insulin is given because insulin is what is deficient. And the other drugs that are used in diabetes also have that effect of reducing blood sugar. So it's a very direct treatment for a chemical imbalance. It's not like that at all with depression. As I said, we don't know what antidepressants do to serotonin levels because they're never checked. And as a result of this, insulin, for example, it's a very precise treatment and it's very refined down to the precision of a single unit dose calculation. Whereas people put on antidepressants, they're generally all started on the same dosage. And there may be a few increased dosages one can use, but it's generally quite limited.